Thank you all for joining this webinar here today. My name is David Kapaon, and I am Research Assistant and Data Manager for the HAALSI project. I'm also joined by Julia Rohr, who is the Project Director for HAALSI, as well as Elyse Jennings, who is one of the research scientists on HAALSI. And we are here to just give you an overview of the project we work on. So without further ado, let's get started. So here is the plan for the webinar. We're gonna give you a background of HAALSI, the who, the what, the when, the where, the how, and the why. Go over the HAALSI sample and our survey. Also talk about some unique features of the data. Talk about how to access the data, as well as some upcoming data releases, and then end with some questions. So first of all, what is HAALSI? HAALSI stands for Health and Aging in Africa, a longitudinal study of an in-depth community in South Africa. And very generally, HAALSI aims to examine and characterize a cohort of just over 5,000 men and women, all of whom are greater than or equal to 40 years of age and live in rural South Africa. And to do so with respect to health, physical and cognitive functioning, aging, and well-being. However, HAALSI is also designed to both address issues specific to a local South African context, as well as harmonize with some of the other international sister HRS studies all around the world. So just for some background, HRS stands for Health and Retirement Study, and the American Health and Retirement Study is actually based out of the University of Michigan, and it's a longitudinal panel study that has been interviewing about 26,000 Americans who are all over the age of 50, for several decades now, and it asks questions about income, about work, assets, pension plans, health insurance, disability, physical health, and cognitive functioning, and healthcare expenditures, just to sort of name a few things. And so HAALSI is supposed to be the South African analog to the US's HRS study and some of these other international studies too. And to just give some example of some of these other international studies, there's LAHSI, which is the Longitudinal Health Aging Study in India. There's also CHAALS, the China Health and Retirement Longitudinal Study, ELSI, which is the Longitudinal Study in Brazil, SHARE, the Survey of Health, Aging, Retirement in Europe, and there are many others as well. And so in this way, HAALSI sort of provides this unique opportunity to compare the biological, social, economic determinants of chronic diseases, as well as their effects on health outcomes in an aging population. Now, you might be asking yourself, well, what is an in-depth community? And in-depth refers to the Indepth network, which is a global network of health and demographic surveillance systems and data projects that's based in Ghana. And the reason why HAALSI is a longitudinal study of an in-depth community is because our main partner on the ground in South Africa, which is the MRC Wits Rural Public Health and Health Transitions Research Unit, was actually one of the founding members of the Indepth network several decades ago. And so by integrating the HAALSI data with this really rather robust cause of death data from the Indepth network and from our partner on the ground in South Africa, we're hoping that it will allow us to explore the interrelationships between physical and cognitive functioning, lifestyle risk factors, household income and expenditures, depression, mental health, social networks and family composition, HIV infection, and cardiometabolic disease, just to sort of name a few. So just for some more background on HAALSI, we launched in 2013, and we currently have 3 waves of study. Our baseline wave, wave 1, occurred in 2014 to 2015. We then had a follow-up wave, wave 2, which was in 2018 to 2019. And then actually, as I speak right now, we are in the process of collecting data for our 3rd wave, which we are projecting to occur 2021 to 2022 as well. And if you're wondering where our sort of study site is, we gather data from the Agincourt study site, which is in the top right-hand corner of South Africa in the Mpumalanga province. So next I want to just talk about who is a part of HAALSI. We have 6 main institutions or organizations that are actually written into the grant: Harvard University, and within that, the Harvard School of Public Health, and we come from the Harvard Center for Population and Development Studies. As I mentioned just a moment ago, our main partner on the ground in South Africa is the Wits Rural Public Health and Health Transitions Research Unit, based out of Wits University in South Africa. We also have researchers at Heidelberg University in Germany, at Stanford University, and the University of California at San Francisco in California, as well as Brigham and Women's Hospital in Boston. However, I think a cool thing of HAALSI is that the family sort of keeps growing. We have past postdocs and other researchers who, although they've moved on from HAALSI, they continue to stay updated about the data and use the data for their own research and their own projects. And so we have researchers in Australia as well, and South Korea, and London, and the Netherlands, and also all across the US too. So next, you might be asking yourself, well, this is all great, but why does HAALSI even exist? What is the justification for why HAALSI was created? And the reason for HAALSI is that currently sub-Saharan Africa is sort of in the midst of this really interesting demographic and epidemiological transition. I think the dominant narrative in sub-Saharan Africa for the past couple of decades has been the HIV epidemic. And this epidemic has caused pretty drastic reductions in life expectancy across many countries. However, the increasing availability of antiretroviral treatment, or ART, which is the medicine that's used to help suppress HIV, this increasing availability of these medicines has actually begun to reverse these declines in life expectancy. And so because of this, we're seeing socioeconomic and health improvements across the region, and these have led to overall gains in life expectancy, which is obviously a great thing. However, these population level shifts and increased life expectancies have also been accompanied by a rise in chronic diseases as well. And so adults throughout much of sub-Saharan Africa are now experiencing the onset of cardiovascular and cardiometabolic diseases at previously unforeseen levels because they're living longer. And furthermore, the burden of these diseases is only projected to increase, if not more than double, over the next 20 years or so. However, to date, little is sort of understood or known about the nature of aging in this region with respect to these sort of transitions. And so the justification for HAALSI is to sort of study this demographic or epidemiological cascade or sort of swirling transition that has been happening, is currently happening, and is projected to continue happening into the future. And so to study this, HAALSI was created. And the HAALSI program currently includes 5 very tightly integrated projects that together we hope will reveal the interrelationships among common chronic diseases, as well as the determinants of population health and healthy aging. And so those 5 projects are Project 1, which is all about cognitive impairment and dementia. Project 2, which is all about cardiometabolic disease in an aging South African cohort. Project 3, which is all about HIV and HIV interventions to promote healthy aging. Project 4, which is all about public policies to improve healthy aging. And Project 5, which is our multi-morbidity project. And so the overarching goals of HAALSI are to identify the biological, social, and economic predictors of mortality, also to identify the incidence of diseases and the onset of new health events, particularly those that are related to HIV and cardiovascular and cardiometabolic disorders, as well as to identify any changes in physical and cognitive functioning since previous waves of the HAALSI study. I would say another overarching goal of HAALSI is to evaluate the health impacts of public health policies and other social policies that are being introduced to reduce salt and sugar sweetened beverage intake, or policies designed to increase the financial security of the elderly, of families in general, of individuals with disabilities too. And finally, as I mentioned earlier, one of the overarching goals of HAALSI is also to maximize comparisons with some of these other sister HRS studies around the world. And so we're hoping that by doing this, it will allow us to increase the capacity to make generalizable statements and understand cross-country comparisons about the determinants of health and aging around the world too. I also think it's unstated, but an underlying theme of HAALSI 2 is that a lot of work about cognition and dementia, about cardiometabolic disease, about HIV, about public policies and multimorbidity has come from high-income countries. And so not much is known about these themes in low-income or low-resource settings, or settings such as these with these rapid demographic or epidemiological shifts. So that I think is also sort of an unstated but underlying theme of HAALSI 2. So next, I want to talk a bit about our sample. This picture is the first part of what I consider our HAALSI respondent cascade as of 2021. And this is the pre-wave sampling we did to get ready for a baseline wave in 2014. So we had identified that there is about 116 individuals in the larger study setting. From these 116,000 people, we created a sampling frame of just about 13,000 individuals, about 9,000 women and 4,000 men. From these 13,000 people, 6,281 were actually selected to participate in our first wave of data collection. However, not all of these actually participated. 231 had passed away in the intervening time period. Another 160 had migrated. And so that left us with 5,890 who were actually eligible for wave one. But again, all these people didn't actually complete the wave one interview. 353 weren't found and 478 were unable to participate for miscellaneous reasons or just outright refused the survey. And so that leads us to our wave one, our magic 509 number, which is the number who actually completed the wave one interview. Again, that was in 2014 to 2015. For wave two, we actually re-enrolled everyone in the sample again. We weren't able to interview people for a variety of reasons. Majority of the reason for why people did not come back for wave two was because they passed away. So about 600 individuals had died in between wave one and wave two. 254 had refused the wave two survey. 34 were unable to be found and 3 had incomplete interviews. And so that left us with 4,176 individuals who actually completed the wave two interview. And so this brings us to present day, our wave three sample, which as I said is occurring as we speak. We have a projected sample of 4,247, and you might be asking yourself, well, wait a second, this number is higher than wave two, and you're correct. We actually didn't have any sort of limiting factor for the sample. The only sort of limiting factor for wave three was if you passed away. So it's entirely possible for someone to have interviewed in wave one, refused the survey, or didn't take the survey in wave two, but has since come back for the sample for wave three and interviews again. So that's a bit about our sample. I now want to talk a bit about our survey. The survey, I would say on a good day, takes about 2.5 hours to complete. So it's a pretty robust and lengthy survey. With that being said, I don't think it's possible to go through all aspects of the survey. So I'm just gonna paint with broad strokes here. These are sort of some of the section names for the first third of our survey, I would say. And I think the general theme of the first third of our survey is focused on economics. So we have questions about household consumption, where we ask the head of the household who purchases the food and how much did it cost and did they produce any items themselves. We also ask about household expenditures and labor income, like whether any members of the household are working for a wage and what their monthly income is. We then ask the actual respondent about if they received government transfers, like a grant or a stipend from the government, as well as how much. We ask about remittances and durables, like the cost of utilities and vehicles that they have, the cost of housing and the cost of land. We also ask about the cost of livestock and how much they have, as well as financial assets, which is their total debts or loans, store credits, savings, and investments, and so on. We then have a couple intervening sections like the background, which is sort of general demographic information and general health and subjective well-being. But then we transition to what I would consider the second sort of large section of the survey, which is all about cognition. And within the cognition section, we have several sort of subsections. So we have a picture naming section, we have a section called trails, numeracy, immediate recall, incidental memory, and retrieval fluency. And I actually think this is a really sort of interesting and unique aspect of HAALSI. So I just wanted to go over a couple of the cognition sections. Trails is actually really cool. A couple sort of shapes are flashed on the tablet screen for the respondent, and then they have to connect these shapes and using a line in certain sort of patterns. So maybe they're asked to connect all the circles from largest to smallest, and as it gets progressively harder, maybe a bunch of different shapes are flashed on screen, and the respondent is asked alternating squares and circles, connect them from largest to smallest, or vice versa, smallest to largest, and so on. Numeracy is like number sequences. So the field worker will read off several numbers that have some underlying mathematical pattern to them. One of the numbers will be left blank, and the respondent is asked to sort of fill in the missing or the blank number. Immediate recall, the respondent has to recall words that were told to them earlier in the cognition section to see how many they remember. Incidental memory, they have to list the days of the week forward and backwards. And retrieval fluency, one of my favorites, they have to name as many animals they can in 60 seconds. I would say the last sort of third of the survey is kind of a grab bag of a bunch of other sections and data points that we wanted to talk about. So we gather data about social conditions and employment and benefits. We gather data about health service utilization, so how frequently they used health services and the cost. We gather data about food security and life history. We do various biomarker and performance tests like speed and walk time. We also gather urine for later testing in a lab. And we ask questions about PTSD, hearing and vision, physical functioning, soft drink consumption, depression, HIV, and intimate partner violence too. I want to highlight a couple of these underlined sections too, not only because they relate to some of the larger goals of HAALSI, but also because I, again, think they're sort of unique. Social network section. In this section, the respondent is asked to name 6 or 7 individuals or alters who are the most important individuals in their life. And we ask about how often they've been in communication with them, what their name is, what community they live in, what their relationship is, and how often they've interacted with this alter for emotional support, for financial support, informational and physical support as well. In the cardiometabolic section, which is again a big fundamental project of HAALSI, we ask about blood pressure, diabetes, HIV, TB, stroke, heart attack, low kidney functioning, smoking, alcohol consumption, and also general diet questions too. And in the HIV section, we ask about the relationships and their time frame and with whom, the number of partners that they currently have, if they've ever been tested for HIV, if they know their status, if they know where to get ART, again, the medicine used to suppress HIV. We also ask some questions about HIV stigma too, such as whether they would buy veggies from a vendor who knowingly has AIDS, if they would care for a family member who has AIDS, if they would allow their kid to be sent to a school with a teacher who has AIDS, and so on and so forth. I also just want to highlight that the sections that have the wave 3 next to them are new sections that we've added for our third wave of data collection too. Now that I've gone over some of the sections of the survey, I also want to talk about some of the biomarkers and point of care tests that we do too. So these are embedded within some of the survey sections, but we gather anthropometric measures, height, weight, hip and waist measurement. We do lipids, which is only wave 1 and wave 3. We also gather blood for hemoglobin and glucose too. We gather urine, which is on a subsample of the HAALSI sample. We also gather DBS, which stands for dried blood spots, and we test that in the lab for HIV, HIV viral load, ART screening, so if they're taking any of these ART medications, HbA1c, which is a marker related to diabetes, and CRP, which stands for C-reactive protein, which is an inflammatory marker. And then we also gather data about blood pressure as well. So next I want to talk about one of what I think is a unique feature of the HAALSI data set, which is sets of inverse probability weights that we actually have in our longitudinal data set. So if you go download our wave 1, wave 2 data from some of the data repositories that I'll be mentioning a bit later, you will see these in the data sets and you can actually use them for your own analyses. Just for some background on inverse probability weights, just so everyone sort of understands what they are. For any sort of longitudinal study, i.e. any study where you are repeatedly following up your sample over multiple time points, whatever those time points are, whether it's every other day, once a week, once a month, twice a year, once every 10 years, whatever it is, it's very likely that your respondents, some of your respondents are going to leave your study. And we actually saw that earlier when I was going over the sample. Some just refuse this sample, the survey, some just don't want to come back, and some migrate. And the reason why you have to be aware of this is because if you aren't, it's very likely that when you conduct your analyses, your results are going to be biased in favor of certain groups over others. So an example in the HAALSI context might be that if a majority of those who interviewed in wave 1 but didn't come back for wave 2 were older, less educated people, then when we run our analyses on this data, our results might be biased in favor of the younger, more highly educated people because we have an overabundance of them in the sample. And so you use inverse probability weights to sort of reweight the sample and up and downweight individuals based on a number of characteristics to sort of counteract this effect. And so in this example, again, that I just said, if we have an overabundance of these younger, more highly educated individuals, once we apply the weights, each of these people might count for like a third of a person or a fourth of a person because we have quote unquote too many of them. Whereas the rare sort of older, less educated person who happened to stay around for the second wave, they may count for 5 people or 10 people because they're sort of an anomaly in the data set. So in our longitudinal data set, we have 5 sets of probability weights, inverse probability weights. We have a set related to attrition. So any reason why someone left the study for any reason other than death. We also have a set of inverse probability weights that are just for death. So any reason why someone left the study specifically because they passed away. We then have 3 other sets of inverse probability weights, all related to consent. And the reason we created these is because when we were looking at our wave 2 data, we realized that there was a lot of missing data with respondents consenting to some of these biomarker and point of care tests that I talked about earlier. And these were sort of pretty important variables to some of our projects. And so we decided to create inverse probability weights to sort of reweight these samples of individuals who didn't consent to these various tests as well. And the reason we grouped them into 3 separate buckets, anthropometric, biomarker, and DBS, is because a lot of the consents were sort of related to one another and had higher correlations. So height and weight, which are anthropometric measures, we grouped those into a consent category and created a set of weights for those. Biomarker, which contains blood pressure, hemoglobin, and glucose, we grouped those together. And then DBS, again, stands for dried blood spot. And so we grouped those together for diabetes and HIV and created a set of weights for those as well. So as I said, those are actually in the longitudinal data set. So if you want to use those, you can download the data and put them into your analyses. The second unique feature I want to talk about is what we call our economic shops data. So this data is actually, it's not released yet, but we're hoping to get it out in the next couple of months. And this is data we gathered on essentially as many, if not all, the shops in the larger area or region that respondents use to buy things. So we gathered data on the type of shop it was. So if it was a supermarket or a formal brick and mortar store, or if it was an informal stall, maybe set up on the side of the road, or a tavern. We also gathered data on the type of goods that they sold, as well as the price of the goods too. So if they sold snacks, beverages, alcohol, these sugary sweetened beverages that I talked about, energy drinks, salty foods, bread, soups, sugary spreads, and other sort of miscellaneous local brands. We also gathered data on if they advertise for alcohol or these sugary beverages too. And we also gathered data on the coordinates, so the latitude and longitude of these sites as well. I should also say that this data is longitudinal, so we have data from both wave 1 and wave 2 about these shops. So you could check over time how the price of certain goods have changed or whether certain shops have stopped or started advertising for alcohol again. So that's an overview of our economic shops data that, again, we're hoping to release in the upcoming months. The third feature I want to talk about is just sort of the general cognitive data that we gather. We have a pretty large sub-study about cognition and dementia, and it's actually on a subsample of the 5,059 individuals, about 600 people. And we collect pretty detailed neuropsychological data, also functional assessments. We gather neurological data and clinical evaluations. And the main part of this data consists of sort of 3 interview parts. So we have a respondent interview, which we ask the actual respondent their subjective cognition rating. We do reading tests, and we do a mental status exam. We go over the days of the week as well. We do word recall, like I mentioned earlier. They do clock drawings too, and semantic fluency. Again, that's naming the animals. And we do many other sort of battery of other cognitive tests too that I haven't mentioned, in addition to the ones in the main survey too. We then have an informant interview too, which is someone who knows the respondent, and we ask the informant the relationship to the respondent. We ask them questions about if they think the respondent has experienced cognitive decline. We also do several dementia screening scales. The informant answers, like the Blessed Dementia Scale, which is a rating of whether the respondent has experienced a loss of ability to do various activities and whether that loss is attributed to mental, physical, or maybe both. The final interview type is a neurological assessment, where we assess neurological signs and symptoms of the respondent. We assess signs that maybe complement or confound dementia diagnoses, so face or muscle weakness, upper and lower limb mobility, gait and balance. We also have a nurse that records signs of tremors or poor comprehension or incontinence as well. We also do vision and hearing in the neurological assessment too. As a sub-study of this sub-study of the cognition subsample, we actually do another sort of data collection called the consensus data, where we have a panel of clinicians who actually review the data for each participant and assign them a final diagnostic category of dementia diagnosis, whether that's normal functioning, cognitively impaired but no dementia, or probable dementia. And the interesting thing about this consensus data, as the name implies, is that the decision about the final diagnostic category has to be unanimous amongst all of the clinicians. And so in cases of disagreements, adjudication calls are actually held and they're led by a moderator until consensus is reached. We also have some MRI data on another subsample of about 100 participants as well to sort of assess the feasibility in a place like Agincourt too. So those are sort of 3 unique features of the HAALSI data. I next want to just talk about how to access the data if you're interested in using any of our HAALSI data sets. We have 3 repositories or sites that we upload our data to. One, which is the Indepth data repository that I mentioned right at the beginning of the presentation. Also, ICSR. And then also Harvard's Dataverse too. So I'm going to go through each of those 3 right now. So if you're looking to download the data from the Indepth network, up on this data repository, we have two data sets, the baseline data set and the longitudinal data set. Just for some sort of background and clarification, whenever I say longitudinal data set, that is both wave 1 and wave 2 merged together. So if you download the longitudinal data set, you also get the wave 1 data set sort of baked into it. And so if you're looking to download from Indepth, here is a screenshot of what the page looks like. This is the baseline wave, but it looks the same for the longitudinal site. And you can download the data from here. There's also the data dictionary and some other documentation that you can download too from Indepth. If you're looking to download from ICPSR, ICPSR currently only has our longitudinal data set. And the reason we did that was intentional, is because we didn't want to have two separate sort of pages for HAALSI, one for the baseline and one for the longitudinal. So we just actually replaced the baseline with the longitudinal data set because it again contains all of wave 1. So if you're looking to download from ICPSR, this is a screenshot of the site and what it looks like. Again, you can download the main data set, and we also have other data and documentation up here as well, like variable crosswalks and such. And finally, if you're looking to download from Harvard's Dataverse, we actually have a couple other smaller data sets up there as well. So we have 7 data sets on Harvard Dataverse. We have the baseline wave and the longitudinal wave, like usual. And then we have several smaller data sets like the baseline dementia wave that I was talking about earlier. We have another small data set called HCAP, which is all about harmonizing dementia screening about across high and low literacy countries. We have our baseline lab wave, which is on a subsample of participants who were invited to participate in additional laboratory visits. And we did testing, additional cognitive testing. We did venous blood and urine collection there too, spirometry, vision testing, EKG, an ankle brachial index, abdominal ultrasound, and various other anthropometrics too. We also have a small data set for DBS, dry blood spot for C-reactive protein, that marker I talked about earlier. And we also have a restricted HIV data set, which contains data about HIV and HIV viral load, as well as these presence of these antiretroviral drugs that I've mentioned too. So this is the screenshot of Harvard's Dataverse page. Again, we have all the data sets sort of listed below. And if you're looking to download this restricted HIV data set, this is what the actual page looks like for this one. And there's several buttons on this page. If you click access data set or request access, I think there's another one too, it actually sends an automated email to me. And then I reply back to you because we just have a couple checks before we download the data. So we ask you to sort of give us a short description of the project and how you intend to use the data. We ask you to fill out a DUA. And we also ask you to get an IRB from your home institution. And then you'll send those all back to me. And then we have our PIs sort of review the request and decide whether to accept or deny the request. So if you want to access the HIV data, that's also up on Harvard's Dataverse. We also have some other upcoming HAALSI data releases. As I mentioned, the longitudinal economic shocks data, which we're hoping to release soon. This sort of all these sets of cognitive data, like the MRI data, the dementia diagnosis, and general cognition data for additional waves too. We actually just uploaded an ApoE genotype data, which is a genetic risk factor for dementia, Alzheimer's, and cardiovascular disease. So you can use that too. And then farther down in the future, we have our wave 3 data set, which we'll probably release in a year or so. I should also say that all these data sets are linked by the same unique key. So you can sort of merge them all together if you want to merge a bunch of the different ones together to create like a unified data set too. So that's all I have here today. I want to thank everyone again for joining the webinar. And if you have any questions, feel free to ask them.
Thank you, David. That was really, really informative. I am going to go through quickly how to access the data through NACDA. and then we will do some Q&A.
Should I stop sharing my screen?
Yes, please. Thank you. And you all should see my screen with an image of the NACDA site. So if you want to download the HAALSI data from ICSR and NACDA, you would go to nacda-aging.org and search for HAALSI. And if you type in HAALSI, the acronym, one study will come up, and that's the HAALSI study, and you can click on that study link. And this is the same page David showed before. It's the study page. And you can see that there's...
Catherine, we're not in presentation mode.
I'm not in presentation mode.
Probably want to click that little slide.
Sorry about that. It's weird on my screen. It does look like I'm in presentation mode.
Oh.
Hang on 1 second. Let me try again. How's this?
I'm still seeing the sidebar. Is she in presentation mode to anyone else? David, what do you see?
It doesn't look like it's in presentation mode for me either.
Hmm.
Try clicking that
However, I
little
can see the slides well.
Try clicking
Sorry about that.
thing down at the very bottom, the little slide.
Yeah.
If that works.
Apparently I'm having technical difficulties. Okay.
Okay, well,
Yeah.
let's just work with what we have.
We might just have to deal with this. Okay. Sorry, everybody, and thank you for your patience. So if you can just ignore that my computer doesn't want to participate and just try to focus on the slides. You'll see that on the study page, there's a download button on the left-hand side, and you can use that if you want to download like a specific, like all the files for a specific format. And that's where you'll go, or you could just download the code book or something to that effect. And then another option is going to the data and documentation tab. And if you click on the download button to the right of the dataset name, you'll see all the options where you can pick and choose all the different format types again here, and you can also preview them here before you download the documentation only. Also, I didn't go into this here, but if you go to the variables tab, you can use the variables tab to search different topics and see what variables are in the data set before you even download. When you download, you agree to some terms of use, and you're basically agreeing to just use the data for ethical research purposes, maintain privacy of research subjects, not to redistribute the data, and to cite the data properly with the DOI, which is the same link that I shared in the chat. You'll want to be logged into your MyData account, and you can log into MyData or register with MyData through Google, LinkedIn, or OrcID. And when you successfully download the data, you'll see this page. And then you'll want to check your downloads folder, and you'll see that it's a zipped package. One common question we get is, why did it come in a zipped package? And this is for internal infrastructure reasons as well as metadata reasons. So we need to support single and multi-data set studies. So if HAALSI did give us more data in the future and they wanted it all in the same study, multiple data sets would have the same metadata collection, would be easier for people to discover. So that was just a quick how you can get it from NACDA. And now we will go to the questions. And I think, let me go to one of the first questions I saw, which is, does wave 2 contain cognitive function questions as well?
So yes, wave 2 will contain cognitive functions. There was some error outputting the cognitive data from the server when we were getting wave 2 ready for submission to the sites. So I think it's not up there now, but we're hoping to replace the data sets, the wave 2 data sets with the data sets with the cognitive data soon.
Thank you. Okay, another question. Is the APOE data available for all participants or just the 600 in the dementia sub-study?
The APOE is actually on about 1,700 participants. I think some in and some in not in the dementia study. So it's more than just the 600 dementia sub-sample.
Great, thank you. And then just a follow-up to the last question is about a timeline. Do you have a timeline for when the cognitive function questions would be updated for that data set?
I think we're hoping to get them out in the next couple months or so. I think we have the current data and we just need to sort of merge it in and then reach back out to all the repositories and upload them again.
Sure, thank you. So we'll say in like a few months. It sometimes takes time to get the data together and then get it released across those sites. Okay, so another question. For the longitudinal data sets, how many visits do you currently have? Is the collection of data elements in line with the waves?
Does this question mean talking about the wave 3 data that we are collecting right now? If so, we have about, I think, 1,500 interviews that we've done so far, although that's not what the question is asking.
Well, I remember you said that there are 2 waves currently available. So waves translates to visits roughly. Is that right? And then the collection of data elements in line with the waves. So maybe this person means, and for the person who asked this, you can give more information in the chat or the Q&A if you like. But maybe they mean the different elements, like the, all the different data that's restricted and whatnot, maybe those elements.
So the data is set up, it's not set up in a panel format, it's set up in a wide format, so to speak. So everything is sort of merged horizontally in, meaning that all 5059 people from wave 1 are still in the longitudinal, the wave 2 data set because it's not panel. So even if someone didn't interview for wave 2, they're still their data is still sort of in the data set.
Okay.
And then all, as I said, all other sort of the future smaller data sets will merge directly to those 5059 too, even if they maybe didn't come back for wave 2 or whatnot.
Okay, thank you. Yeah, the same person mentioned they're interested in jaunt modeling longitudinal markers with health outcomes, CD4 cell counts and deaths.
Yeah, so just
joint modeling.
Just to add in, like you said, we have the 2 waves that are currently, and we're in the field for wave 3 right now. So hopefully that will be released in maybe a year and a half at most from now.
Okay, great.
Here, hopefully, yeah.
Thank you. And yes, there's a question about the sharing of the slides. We definitely will share the slides for the presentations after the webinar is over. I think registrants will get those pretty quickly, but then we'll also do some quick checks on them and release them through the NACDA site announcements as well in a couple days after that's all settled. Okay, so another question that we have is, what is the format of the data set and how are the variables labeled to distinguish between waves?
So as I said, it's not a panel data set, so there's not multiple observations for a single unique individual. Everything is merged in horizontally. And for each variable, the way we have it set up to identify a variable is the way we name it is first the wave a variable came from, a 2-letter section identification code, and then a 3-digit number. So for example, going back to when I was outlining all the different sections for the wave, if you were looking for a question from the food security section, maybe the 4th question, from the third wave, the variable would be W3FS004. And so all the questions are sort of named according to that format too. And then if we end up adding a new question that hasn't been in previous waves, we just stick that number for the first number in the 3-digit code to sort of show that it's a new variable.
Thank you. Okay, we have another question about biomarker variables. So this person, it says, thanks so much for a great presentation. I was told the biomarker variables such as HB1AC collected disproportionately more from the younger groups of the cohort. Is this true? And is there a plan to collect biomarkers from the older groups as well?
David, I can also jump in on part of this question if you want. So most of the biomarkers like HbA1c and as David mentioned, all the dried blood spot biomarkers are collected on everyone. So it's not disproportionate for the younger members of the cohort. But maybe what this person is referring to is that in wave 1, we had a lab sub-study that collected additional biomarkers on top of the DBS and point of care tests that are in the data set. And that was on a sample of people aged up to age 70. So it was missing the older half of the cohort just because those people had to travel into a lab to get some additional testing done. But the main kind of HAALSI biomarkers that were collected through dried blood spots are collected on everyone. So that would be the HbA1c, the C-reactive protein, and the HIV data as well.
Thank you. So we have a couple more questions still. So thank you everyone for your great questions. So the same person had a question about how to read the age of the participants. They're not sure how to read different household member age variables. And if there's if some of these maybe require a follow-up after the webinar, if you have any kind of contact that you'd like people to reach out to, please feel free to state that. And also just so people know, you can email the ICSR help email or ICSR-NACDA@umich.edu if you have questions after the webinar that you'd like to follow up on.
Yeah, I can put an email in the chat too or something. To answer the question, we have a general age variable for all the respondents, but then we have household member age variables for the number of members of the household who currently live in the household, and then we also have age variables for each of those individuals as well.
Thank you. Okay. So there's another question. Is there a crosswalk available for the study?
Yes, there is a crosswalk. I think it is on ICPSR. It shows all the variables that are the same across wave 1 and wave 2. It also gives reasons for variables that we may have dropped, because the survey text is also up there too. And so you may see variables in the survey text that aren't in the actual data set. And so we give explanations for why we may have dropped those if it was an identifiable data, or if it sort of got exported from the server incorrectly and we couldn't fix it. But the variable crosswalk is up on ICPSR.
Great, thank you. And we have another question. Are you gathering any COVID-19 data?
We are. We actually we have a COVID phone module we just managed to scramble together for wave 3. It again is also happening right now. And it's all done via phone call too. And we'll probably release that 6 months after data collection ends or so.
Thank you. Okay, does anybody have any other questions? We have a few minutes left before the hour we planned is up. So if you have any last questions, sneak them in now.
I wanted to jump in, Catherine, and remind everyone that support for the HAALSI study continues after the webinar. That NACDA is available through email, through phone calls. And if you have specific questions about the data structure, finding variables and things, we'll be happy to set up an e-visit with you so we can sit down and go over the data. If you have questions that are specific to the study design, send it to us, and then we'll make sure they go to the right person on the HAALSI team to get you a faster answer. It's generally more efficient to send us the questions because we know who to contact rather than just bombarding the research team with questions. So we're available at any time to talk about this study or any NACDA study.
I also just put an email in the chat too if anyone has any follow-up questions. Absolutely feel free to email that email and I can follow up with you about any questions you have.
Thank you so much. Thank you to all of our presenters. It's been wonderful to have you here and talk about the HAALSI study. We're excited to have these data at NACDA and ICSR, and it will be great to see what secondary use people get from them. And if you're out there and you're already using HAALSI and you have publications, please do share your citations with ICPSR and we can link them to the HAALSI study to show the research community just how valuable these data are. And it helps across the research community to show particularly new researchers the different ways the same data set can be used. Okay, so I think that's all of the questions, and we're just a couple minutes before the end of the hour. And thank you everyone so much for being here today, and to our presenters, you did a wonderful job, David. And we will share the slides and the presentation recording as soon as we do all the compliance checks.
Great. Thanks so much for hosting.
Yeah.
Thanks to everyone for attending.
Thank
Yeah,
you.
definitely. Thank you for joining.
We're getting some thank yous from attendees and we really appreciate that. So take care, everybody, and enjoy the rest of your week.